Welcome to this series of educational modules titled Mechanical Circulatory Support, Bringing Clarity, the Why, When and Who. My name is Professor Simon Redwood and I'm an interventional cardiologist at St Thomas's Hospital in London, and I'll be introducing and chairing these sessions. The main purpose of this session is that it is well known that the balloon pump is the first choice for mechanical circulatory support for cardiologists throughout the world. However, their appropriate balloon pump therapy has been subject to very heavy debate. Importantly, there appears to be a dichotomy between the clinical trial results and real-world practice. And the purpose of this series is to present a review of the physiological principles behind mechanical circulatory support and discuss the dichotomy between trial results and real-world practice and how that should reflect on patient selection. Welcome to this module, the Clinical Enigma, Randomized Trials versus Clinical Practice. And I'm delighted to introduce Nico Pils, who's a professor of cardiology at the Catharina Hospital in Eindhoven. What we're going to be talking about today is why the current prospective trials of balloon pump therapy did not meet their endpoints and the emerging science of the selection of patients who would benefit from intra-aortic balloon pump. Nico, welcome.
Thank you for this introduction, Simon. In fact, when we are talking about IABP, there is the clinical enigma, which says that in some patients we see dramatic improvement of clinical condition after inserting an IABP, and in other patients we do not see any effect at all. Many retrospective studies have shown benefits of IABP, whereas in some prospective recent trials, no differences were seen. So the point is, why do we observe those differences? And how do we select patients who will benefit from IABP? Let's first have then a short review of the two last trials. The SHOCK 2 trial, which encompassed 600 patients with acute MI complicated by cardiogenic shock and planned for primary PCI. They were either randomized to PCI plus IABP or PCI only. And the primary endpoint was a 30-day mortality. What we have seen in this trial was that there was a very high crossover rate in the PCI-only group. 10% of these patients got an IABP as well, and more than 5% was crossed over to an Impella or another assist device. On the other hand, there was also some crossover, 4% in the IABP group, but that was due to the fact that these patients died immediately before an IABP could even be started. So there was this very high crossover rate, altogether 15% in the PCI-only group. What does that mean? It means, in fact, because it was an open trial, that most likely the worst patients from the control group received additional treatment. Because, why? At least at the judgment of the treating physician, that was considered to be useful. This means that there was a positive bias in favor of the control group. On the other hand, the crossover in the IABP group due to immediate death before IABP could be started means that the worst patients in the treatment group, the ones with the highest risk, could not be treated by the IABP. So this means a negative bias for the treatment group. Sure. So this so-called selective crossover creates a serious bias. And if use of an additional support device would have been part of the primary endpoint, which statistically should have been done in such case, it would have been a positive study.
But the other point is that the balloon pumps were actually put in the patients that were randomized balloon pump. About 90% were put in after the angioplasty.
Yes, that is another issue. We do not know exactly what that means. It could be suggested that putting in it prior to the PPCI would have been better. On the other hand, that doesn't take away the negative bias for the IABP
sure.
and the positive bias for the control group by this high crossover rate.
Of course.
I will come back to that high crossover rate later. Let's have a look at a CRISP AMI trial. About 340 patients with STEMI within 6 hours admitted for primary PCI. And these patients in STEMI should be present, which was defined as 2 millimeter ST elevation and at least 2 adjacent leads. And these patients were randomized either to IABP prior to PPCI or no IABP. And the endpoint was the infarct size after 5 days by MRI. If you look at that study, there was no difference in infarct size or any other MRI parameter. At 6 months, there was a strong trend towards a lower mortality in the IABP group. And at 6 months, there was a positive difference, a significant difference, in favor of the IABP and the composite endpoint of death, shock, and heart failure. But if you look more close to this trial, there also was a number of limitations. The inclusion criteria were not very robust. In more than half of the patients, there was a very limited amount of myocardium at risk, small infarctions. And in such patients, whatever treatment you install, you will have a good outcome anyway. So there was a dilution of the benefit, which means that in fact the study was severely underpowered.
And the patients were actually quite well, weren't they? Their average blood pressure in
Yes,
the group
they all
was
had a good blood
130
pressure.
over
Yeah,
80.
exactly. So if you have small infarctions, even if you do not treat them, majority will survive.
Sure.
So if you take an endpoint, for example, an endpoint of mortality, when you are comparing two unguents for skin disease, you will never find a positive effect.
Of course, yeah.
As in fact the case. The other point in CRISP AMI was that if you had a good reflow after primary PCI, and that was the case in many patients, you had solved the problem and only little additional benefit could be affected from the IABP. Also in this study, by the way, there was a rather high crossover rate in the PCI only group.
And in fact, interestingly, that's what we saw in BSIS-1 as well. The crossover rate
Yes.
is very similar.
Yeah, and that is a problem with all this kind of studies, as I will discuss in a minute.
Sure.
If we further look at the CRISP AMI study, at the 30-day mortality, we saw that there was a trend in favor of IABP if you look at all patients. But if you sort it out, those patients with large myocardial infarctions, and especially those who had persistent ischemia after primary PCI, indicating no reflow, there was a significant advantage in terms of mortality at 6 months.
So do you think using the inclusion criteria of just less than 6 hours for an anterior infarct was a mistake?
Yeah, well, it is the same as was discussed in the first module. Are you just roughly defining a population and are you tailoring your treatment on that rough criterion, or do you select the individual patient?
Sure.
And there are many patients, 8 hours or 10 hours after infarction, who had a PCI, but thereafter still have chest pain and still have persistent ST elevation. And these patients, most obviously, can benefit from a treatment which can relieve that ischemia at that moment.
Of course. Yeah.
In general, if you look at these studies, you can wonder if an intention to treat analysis is suitable to analyze these studies. And the answer should be no. If you look from the statistical point of view, there are a number of prerequisites for an intention to treat analysis. In the first place, you should have a double-blind study. And by definition, these studies are not double-blind. There should be a large sample size and a relative low event rate, which was not the case here either. And the most important one is that there should be a low and non-selective crossover rate. And especially if crossover is driven by failure of the one treatment strategy, you are introducing serious confounding, because there will be a positive bias in favor of the control group and a negative bias for the device group. That's unavoidable. And you can only avoid that when you take crossover as a component of the primary endpoint.
Sure.
As a response to that, some people, also the investigators of SHOCK 2, proposed to use an as-treated analysis. And they said, well, if you do an as-treated analysis, there is no difference between the two groups either. But also an as-treated analysis is not suitable for analyzing these studies. If you have a high asymmetrical crossover rate and you do an as-treated analysis, it means that you are simply changing the baseline characteristics of the groups. What you do is moving the worst patients from the control group to the treatment group.
Of course, yeah.
So what you are doing is changing the baseline characteristics. And if you do not find any difference, it just means that using a balloon pump in a very bad population gives the same results as using no balloon pump in a good population.
Yes, of course.
So in fact, it suggests that there should be a difference in that way. In summary, in the prospective randomized controlled trial study benefits of IABP, there was always a serious negative bias and confounding, which masked almost by definition any potential effect of IABP. And that is the fundamental problem. You mentioned that in open studies, when you are in a back-to-the-wall situation, when you are dealing with patients which are very ill, which have a high mortality, and that's of course the case in many studies we are performing in IC units. And the only way to circumvent that is either to forbid crossover, which is difficult often from the ethical point of view, or to add the crossover to the primary endpoint. We do that in the SEMPER 5 study, which I will discuss in a moment. And this brings us also to the issue when a balloon pump does make sense. Should you just give it to a roughly defined group of patients, or should you tailor it? Compare it to giving antibiotics to patients with fever. If you say fever, I give antibiotics, you will find a negative effect of antibiotics because fever is mostly of viral cause. But if you tailor and you say, first I like to find out is it a viral disease or a bacterial disease, and then you give antibiotics, then you find a good effect in the good target group. What do we expect from a balloon pump? We expect an increase of diastolic perfusion pressure, but we should realize that that does not increase coronary blood flow or oxygen supply under normal circumstances, because the autoregulation is effectively counteracting any IABP effect. So in a normal circumstance, you cannot expect to find any noticeable effect of IABP on coronary blood flow. But when autoregulation is exhausted, then increase of perfusion pressure and IABP is expected to become effective. And when is coronary autoregulation exhausted? We know that is the case with very low diastolic blood pressure, it is the case with very critical stenosis, and it is the case with ongoing myocardial ischemia, as in acute phase of MI, with no or insufficient reflow, patients who have persistent ischemia despite adequate stenting, and it is also sometimes the case in patients after cardiac surgery. And these are typically the circumstances where coronary blood flow is directly proportional to diastolic perfusion pressure. So if you have a large STEMI, when do we have to use a balloon pump? Well, we can expect that it is useful if there is still viable myocardium, patients who still have ischemia, chest pain, persistent ischemia despite an unobstructed coronary artery. If you have put a stent and the patient has still complaints afterwards, chest pain, and there is still a very poor resolution of ST elevation, then you have a situation where you can expect that a balloon pump
even
makes
in the
sense.
absence of hemodynamic compromise.
Yes, of course in case of hemodynamic compromise, those are the worst patients, but even if you have a large infarction and your patient is still stable but has persistent chest pain and persistent ST segment elevation, you can assume that by increasing diastolic perfusion pressure, you will increase blood flow, you will counteract, so to say, the no reflow phenomenon. This in turn will give a better oxygenation of the myocardium and can improve also the circulation. We tried to validate that, and we started to do that in the so-called ex vivo beating pig heart. And this is a fantastic model. We take the heart out of a slaughter pig, we put it on ice, bring it to the lab, and we instrument it. We can put all instruments around it we like. And then we warm it up, connect it to the heart-lung machine, and we are able to do all these hemodynamic testing to stimulate infarctions, to test the effect of a balloon pump in the way we like.
It's really a very elegant model.
It is an elegant model, yes. And in this beating heart model, we can independently control the afterload, the preload, the contractility, the arterial oxygen saturation, the heart rate, and we can measure all these parameters, and in addition, continuously cardiac output, coronary blood flow, and myocardial oxygen consumption. And in that model, we switched off the coronary autoregulation. We introduce a number of hemodynamic states, ranging from healthy, normal contractile state, to pre-shock and to shock. And superimposed on that, we were able to induce a large myocardial infarction with persistent ischemia. And thereafter, we tested the effect of IABP in all these different clinical scenarios. We switched the IABP on, we switched it off, and we did all the measurements very reproducibly. And what we found was the following. That is this slide. The solid bars here are the different hemodynamic states. The green one is the healthy contractility, the yellow one is the pre-shock, and the red one is shock. And if the hatched bars are added, that is the persisting ischemia. And what you see here, a very nice analogy to what was shown in the first module by Dr. Pereira, is that coronary flow in such a case can increase by up to 50% by using a balloon pump. And a balloon pump is most effective, as you see, if there is the combination of pump failure and persistent ischemia. Persistent ischemia is important. And cardiac output in such a case, that is on the right-hand side of the slide, increased up to 20%.
So in the absence of ischemia, the effect is very, very
It's minimal.
minimal, isn't
It's not very large. Ischemia is one of the conditions which is important.
Which has to be present.
Yes. In fact, you can say it is the exhausted autoregulation, which makes that the balloon pump is increasing coronary blood flow, improving the oxygen supply to the heart, and thereby improving the clinical condition. And you see that also here when you look at the myocardial oxygen consumption. In the absence of ischemia, the solid bars, there is almost no effect on the oxygen consumption, but in the presence of persistent ischemia, by switching on the balloon pump, also the utilization of oxygen by the myocardium is increased by 25%. So the conclusions of what I like to say is that in the several large prospective RCTs like SHOCK 2 and CRIS AMI, these studies are hampered by inappropriate patient selection. It is not specified enough, not tailored enough, and on top of that, there was an inappropriate statistical analysis. And as a consequence, I believe that such trials should be considered as non-conclusive. And in fact, if you would analyze them in the right way, even they would indicate efficacy of balloon pumping. And the second point is that IABP may be particularly useful in patients with viable myocardium, suffering from persistent ischemia despite an unobstructed coronary artery. And that is, as I mentioned, the acute STEMI with successful stenting but no reflow, and cardiac surgery with good bypasses but stunned myocardium. In such cases, there is an improved blood flow to the myocardium, an improved oxygen utilization by the myocytes, thereby improved contractility and cardiac output, and salvage of myocardium with an improved long-term outcome. And let's say as a synthesis of that, we recently started the SEMPER 5 study. In that study, we have patients who are admitted with a large myocardial infarction, assumed ST elevation more than 50 millimeter. They have a successful primary PCI, but then immediately thereafter a second ECG is made, and if the patient has less than 50% ST segment resolution, we define that as persistent ischemia, and these patients are randomized to receive IABP or not to receive IABP. And the endpoint in this study is just the mortality or the necessity to switch to other devices within 6 months.
And roughly what sort of proportion of patients do you find have that?
Of all infarctions we get, about 1 in every 7 fulfills these criteria.
So it's quite common.
Yeah. In fact, 1 out of every 3 patients has a big infarction, a large infarction. But fortunately, and quite a percentage of that, after placing the stent, the pain disappears and the ST elevations disappear. But of those group who get a good stent, have a good epicardial reperfusion, still in 1/3 of them there is this persistent ischemia.
Right.
And these are the ones who should benefit. And that's in fact also what you found in the CRIS AMI study. If you filter those patients out from that population, you see that there is a significant improvement in survival if you deal them with the IABP. Yeah.
Great.
Yeah.
Well, we look forward to the results. Thank you very much, Nico.
Thank you.
So in summary, in this module, we reviewed some of the clinical trials looking at the use of balloon pumps and discussed in detail the limitations and why they apparently haven't shown a clear benefit for balloon pump. And importantly, Nico has developed this very elegant model to try and prove what we firmly believe is the role for balloon pump, and has shown in this model that persistent ischemia seems to be a prerequisite for balloon pumps showing a clinical benefit. And furthermore, he is trying to prove this with an ongoing prospective clinical trial. Nico, thank you very much.